Can everyone see the slides?
Yes.
Yep.
Lovely. Just a quick introduction before I turn my camera off. I'm Vicky. I'm one of the health protection practitioners for UKHSA. My backgrounds, I've been a practitioner. I've been for 3-4 years with a little bit of a break in between, where I worked in a safeguarding role, health visitor by background. And going to just present this short presentation about flu. If you've got any questions, if you can either put them in the chat box or wait till the end, I'd appreciate it. And also just to let you know that I normally deliver this with James Chidler, but unfortunately he's had to leave for the day, so you've just got me, so just bear with me if that's all right. Okay, just turn my camera off. Okie dokie. So a little bit about what flu is. So it's flu's an acute viral infection of the respiratory tract. Usually affects sort of the nose, mouth, throat, bronchial tubes, and the lungs. It's a highly infectious illness. It spreads rapidly in close communities, and it's spread via droplet inhalation, by hand-to-mouth and eye contamination from infected surfaces or respiratory secretions from an infected person. Even people with mild or who are asymptomatic can infect others. And most cases in the United Kingdom occur within an 8 to 10 week period during the winter. On average, incubation for the flu virus tends to be between 1 and 5 days, with an average of 2 to 3 days, but that can be longer in individuals who've got a immunodeficiency. Okay, so a little bit about the science. I'm not a scientist, so just bear with me. So the flu virus A consists of 2 surface antigens, as you can see on the little diagram. We've got the little red ones, which is the N, which is the neuraminidase antigens, and then we've also got the blue ones, which is the hemagglutinin. So the role of the H antigen is to bind to the cell of the host, and there are approximately 16 different types of H antigen. The role of the N antigen is to release the virus from the cell surface, and there are 9 different types of the N. The different types of H and N are identified by different numbers. So, for example, you get H1N1 or H3N2, which are the ones that you've probably heard of. Lovely. So, common features of flu. And as I've had this pointed out in previous training sessions, this doesn't include man flu. So common symptoms include sudden onset of fever, chills, headaches, general muscle aches, fatigue, and joint pain. You've got your cough. It tends to be more of a dry cough than a productive cough. That's usually more indicative of sort of chest infections and other respiratory viruses. And runny noses, stuffy noses, and in particularly in young children, episodes of diarrhea and vomiting can be seen, which obviously can present quite similar to other winter viruses such as norovirus. So serological studies in healthcare professionals have shown that approximately 30 to 50% of influenza infections can be asymptomatic. But the proportion of asymptomatic presentation does tend to vary on which strain of flu is circulating. Usually in healthy individuals, flu is unpleasant, but generally self-limiting and recovery within sort of weeks, sort of 7 to 10 days. Complications of flu. Quite common, sort of bronchitis, otitis media, so earache, particularly within children, sinusitis, and secondary pneumonia infections. Less common sort of meningitis, encephalitis. But those that are most at risk from serious illness is those children, particularly those under 6 months, pregnant women, older individuals, and those with underlying health conditions such as sort of chronic lung disease, cardiac disease, long-term neurological conditions, or those who are on either got immunocompromised immune systems or immunosuppression. And flu during pregnancy may be associated with perinatal mortality, prematurity, and generally smaller neonatal size and lower birth weight as well. So, diagnosis of flu generally tends to be, observation of raised temperature, shortness of breath, that dry cough that I mentioned before. It can be seen on, changes can be seen on chest X-rays, but that would only be a test that would be done within a clinical environment. It's obviously not one that can be relied on. And in terms of sort of testing, there is PCR and viral culture testing available, and serology, but it's not routinely tested for. And what we tend to do is test where we have a high suspicion of outbreak, particularly amongst our more vulnerable settings such as care homes. Rapid testing is available. Again, this is sort of point of care testing. This tends to be seen usually only in hospitals. It is quite expensive, but obviously, does, particularly in the current climate where we've got COVID and potentially flu circulating, obviously it does give that quicker access to diagnosis. So definition of outbreak would be sort of 2 or more cases within 48 hours, raised temperature, so pyrexial, acute onset of cough, hoarseness, nasal discharge, congestion, generalized shortness of breath, sore throat, wheezing. Or particularly important to note that maybe not any of these symptoms, but an acute deterioration in physical or mental well-being. And this is particularly important to note within the elderly population, because, as I say, sometimes it is an atypical presentation of flu. So, as I mentioned before about the obviously we've got the difficulties of having things co-circulating. This is just a slide that gives a really nice explanation of the differences between COVID and flu. And as I say, it's really important to recognise that symptoms are quite similar. Birth can be asymptomatic, and birth can cause fatality, particularly if not recognised or left untreated in the vulnerable individual. It's possible to transmit birth viruses asymptomatically. So incubation for COVID tends to be longer than flu. Incubation from exposure to flu tends to be a shorter period, usually 1 to 3 days, but can be up to 5 days. And the infectious period, again, for flu tends to be shorter, from sort of 12 hours to sort of 3 to 5 days after the onset of symptoms. At the moment, in terms of for treatment, antivirals are not currently approved for COVID-19, but we do have antivirals available to us for treatment of flu. So that, again, just focusing more on the symptoms for flu, it would be, pyrexial, temperature of above 37.8, new onset or acute worsening of 1 or more respiratory symptoms, such as a cough, hoarseness, nasal discharge or congestion, any shortness of breath and sore throat. And as I said, that list's sort of not exhaustive. you know, and that's where, you know, clinical assessment is really important. Generally, there are quite a lot of other symptoms that are now associated with COVID, as our understanding has strengthened. Other symptoms of flu include sort of headache, generalised malaise, muscle aches, and joint pain. Lovely. So outbreak case definition. So COVID, fever, new cough, lost sense of taste and smell, as we all probably are well rehearsed in. Flu, not quite as more tends to be that raised temperature, acute onset, and as I say, going back to that you know, point before about just general deterioration. You know, quite often when you speak to your care home settings, they know the residents very well. You know, they work with them day in, day out, and they're very good at recognising, you know, changes in their sort of behaviour and general well-being. So it's, you know, really important to take that history from your settings, because as I say, they're the expert in their residents. So generally, prior to life before COVID, I don't know if anybody can remember life before COVID, flu was determined to be circulating once it was widely seen within the community. And at that point, GPs would be able to prescribe antiviral treatment and prophylactic treatment of flu. As I said, it isn't the only way that it can be prescribed. It doesn't have to be defined flu season, but you know, it usually was a point of time when, you know, it was generally more widely prescribed. But getting to a point where we knew flu was circulating was important. So that's why interventions such as swabbing are necessary. So I'm going to the next slide is just about a scenario. So a little bit of interaction would be really helpful. I'll talk through the scenario on the next slide. So our scenario 1 would be, so we've received a call from the manager of a care home. We have 6 out of 22 residents who have symptoms of runny noses, coughs and fevers. We've got 1 out of 50 members of staff who are also symptomatic. The manager of the care home wants to know should the care home close, and what information do we need, and is this defined as an outbreak? Happy for people just to give a shout out or put the hand up, whichever people are more comfortable with.
So we'd want to ascertain some more information about the symptomatic staff and residents. So when the first person became ill and if there's any connection.
Yeah, absolutely. Yeah, finding out, you know, what the picture's been, how it started.
Has been done to identify what the causative organism is. And we'd also want to know if those staff member could have had contact with other people as well.
Okay, yeah. I saw a couple of hands go up there. I can see I've got Fiona and there was somebody else, but I don't know whether it's gone down.
Yeah, mine was just to ascertain if it's possibly COVID as well. So when was the last time they did whole home testing?
Absolutely, yeah, really important. And do we think we've got an outbreak situation going on here?
Looking that way to me.
Yes. Yeah.
Yeah. So definitely meeting that definition of an outbreak, 2 or more cases within within the defined time scale, usually say within 48 hours of each other. So yeah, next slide for us, please, Kerry. Thank you. Yep, so just to recap, so yeah, we want to know what sort of residential setting it is, what type of care home, what type of care they're providing, layout of the home, how many staff and residents that there normally are, who's the main contact person, which is really important because, you know, to try and get, you know, particularly if we need to do interventions such as swabbing and prescribing of antivirals, having that single point of contact is really useful to make sure that it's done efficiently and, you know, within a reasonable time scale. Also asking questions around vaccination, you know, that's of flu and COVID vaccination, and asking when that had taken place. As we've already mentioned, number of cases amongst staff and residents, asking the setting to you know, create a line list, you know, not necessarily that we need to have the individual's names and details, but so that the setting's got a record of who's been affected, when the onset of symptoms were, and you know, any interventions or treatment that's been given, for their record keeping, and the onset date of the first and the most recent case as well. So we would also ask about the clinical symptoms. So again, going back to those, that presentation, fever, cough, things like that, and say generally as I say, the settings when you call them will be experts in their own residents and what's actually happening. If there's been any hospitalisation or any deaths that have been, you know, particularly those that have possibly been associated with the outbreak. So say if there's been any hospital admissions and a respiratory screen has been completed, or any, you know, any deaths that have been unexpected amongst residents. As somebody mentioned about the COVID testing results, and again, just asking about the timescale which these have been taken in. You know, because that's particularly important as well, because if it's been you know, a significant period of time, you know, we may need to do COVID testing alongside any respiratory screen testing. Asking if any swabs have been taken, and then also, you know, early conversations about whether, you know, whether anybody has prescribed treatment or prophylaxis treatment, and also asking information about the GP who covers the home. And again, that's quite important because quite often there can be multiple GPs that cover particularly large settings. So a bit more information about the scenario. So what we found out is the home is an assessments and therapy centre for patients with dementia. The care home is on a single floor with separate lounges. All cases are confined to one lounge. 21 out of the 22 residents have had their flu vaccine, and one GP practice covers the home. The GPs visited this morning, prescribed antibiotics for one patient, advised good diet and rest, fluid and rest for the other residents. 6 out of the 50 staff now have flu-like symptoms, all LFT negative. 2 have had PCRs and are negative for COVID. What would our next steps be? Has anybody got any suggestions? Again, please interact with us. That would be great.
I guess at this point, if you haven't already done swabbing, then you'd be wanting to swab for flu if the COVID vaccine, COVID swabs have come back negative.
Yeah, absolutely. And do you know approximately how many swabs we'd require to?
5.
Yeah, absolutely. And is everybody aware of sort of the process for obtaining swabs? I mean, I will discuss it a little bit further on in the presentation. So we just need discussion with ourselves at UKHSA, obtain an ILOG, and refer to local arrangements for swabbing as well. Any other steps that people would do? Any advice that would be given? Yeah, got a hand up from Victoria.
I think minimising the communal areas if possible, because you said they're all confined to one lounge, so
Yep.
maybe
Yep.
minimising that contact.
Yep. So yeah, maybe they can, maybe if possible, can more of them be cared for in their own room again to stop spread.
Yeah, exactly.
Any other sort of basic advice that we would give, Lynn?
I was just wondering whether you'd recommend sort of other people not coming in, like in COVID, visitors, etc.
Absolutely, home closure would be absolutely reasonable. Because we want to try and reduce flow, which again reduces movement through the home, which reduces potential spread. Because as I say, it can, as I mentioned earlier, it can be stuck to those surfaces. And we've got Lynn.
Sorry, I've forgotten to put my hand
Oh,
down.
that's okay. Sorry, was it a legacy one?
Yes, sorry.
So, if you can just click on for us, Kerry, that would be great. So the absolute basics that we need to provide is that infection prevention and control advice, really, really important. That is how we're going to stop spread through this home. We can do all the swabbing and give all the antivirals that we like. But, the principal intervention is going to be that infection control advice. Obviously, determine is it flu? Is it COVID? Is it a combination? Is it something else? Or is it, is it co-circulation, COVID and any other of the respiratory viruses as well? Considering if we are in flu season or if we've got intelligence that, flu is circulating in the community. So obviously we're at a stage at the moment across the country that we are seeing some evidence of flu circulating, but not certainly at the levels that we expected prior to the pandemic. Absolutely, as somebody mentioned, and we've discussed a little bit, arranging swabbing of the most recent cases, up to 5 residents, and obviously just speaking to ourselves. Obviously you can see it says PHE there, but obviously we mean at UKHSA. We can just get that ILOG and refer to the local pathways in terms of who carries out swabbing for flu. If we will talk a little bit more about antivirals, but obviously if we're within time scale of being able to prescribe antivirals, both treatment and prophylaxis doses can be organised. Informing hospital infection control teams if you've got any of the residents that have been infected, and contacting any community infection control teams who may be able to provide support to the home if there's any particular infection control issues. And again, we're in quite a different picture at the moment with the pandemic, because general wearing of PPE is still occurring, which prior to the pandemic, it didn't happen, and even in outbreaks of flu, PPE wasn't routinely worn. Obviously, again, consider contacting ourselves, whether, if it's a particularly complex situation, you've got any sort of co-circulation, or, you've got residents who are particularly unwell, or, a high mortality rate, considering requesting additional support, and you're thinking about an incident meeting if required. So just a little bit about infection control. So this really is your general bread and butter advice that we'd be expecting to be provided to your settings. This will be the primary intervention that will prevent the spread of any respiratory or flu-like infections. So recommending that all staff visitors who enter the care home must follow the general principles of the catch it, bin it, kill it. There's lots of literature available online and posters. We can provide posters, and they're available in all the online resources as well. Recommending use of disposable single-use tissues to cover the mouth and nose when coughing, sneezing, wiping, blowing noses, and obviously disposing tissues in a promptly fashion within a bin. Practicing good hand hygiene by washing with soap and water and drying them thoroughly, and particularly important after coughing, sneezing, or using any tissues. Symptomatic residents should be provided with tissues and hygienic methods to dispose of them. Hand hygiene needs to be performed by all staff following the World Health Organization 5 moments guidance. So that's before touching a patient or resident, before clean or aseptic procedure, after exposure to body fluids, after touching a patient, and after touching patient surroundings. And again, really important to reiterate the use of soap and water rather than reliance on alcohol gel, because alcohol gel will only physically clean hands. So other infection control measures that you would be expecting to give advice about is ensuring that there is proper hand washing facilities available with the soap and water. As I say, alcohol gel to be available, but supplementary to hand washing. As I said, because we've got a higher usage of PPE at the moment, ensuring that donning and doffing process is adhered to. And again, there are lots of resources online that care homes can access in terms of, revisiting training about the donning and doffing process. And I think we've, certainly seen on discussion with our care homes, sometimes it is important to just remind them of that process, because, we're at a point in the pandemic where, care assistants and care home workers have been doing this for a long time now. It's easy to not do it in the correct way, and obviously that can contribute to spread of viruses such as flu. And again, just reiterating that hand washing before and after the donning and doffing process. Environmental hygiene, so making sure rooms are clear of clutter. There aren't things like fruit bowls, tins of biscuits that are hanging around, because they're really nice vectors for these type of viruses. Regular touch point cleaning, and that needs to be done with chlorine-based solution, and also making sure furnishings are cleaned regularly. Linen needs to be, from suspected or confirmed cases, needs to be placed within an alginate bag. And as I say, we need to consider and probably highly recommend closure if an outbreak is suspected, and also reducing non-essential transfers. So again, if there's hospital appointments, things like that, it's reminding the settings that they need to contact the hospital and have that discussion about whether it's an essential visit, because what we want to do is again just try and prevent the spread of any virus. Trying to ensure that residents are cared for within their own room, or where that's not possible, cohorting of residents. So for example, in the scenario earlier, they were using cohorting methods, as in using that symptomatic residents were using one lounge area, but as they're just generally trying to reduce movement of staff and residents where possible. And again, we've probably seen it more so during the pandemic, staff being kept to one area rather than crossing over between several different areas of a home. For example, if they've got a residential or and a nursing side as well. And one of the other really important interventions is vaccination. So it's just using any opportunity you can to promote the uptake of the vaccine amongst the residents and the staff. And as I say, actually, I've just seen that I've left myself a little note there about the PPE. So yeah, during PPE usage during the pandemic, so pre-pandemic, the guidance was that it was recommended for suspected flu cases, but not actually mandatory. Whereas, as I say, with COVID, it's obviously more of a mandatory requirement that PPE is worn. So again, that will contribute to reduction of spread, hopefully. So yeah, just a little bit about swabbing. So we'd recommend that if swabbing does take place, it's important for the management of the outbreak. It's also really useful for surveillance purposes to give ourselves at UKHSA and your local authorities information and intelligence about what is actually circulating. We'd recommend a respiratory virus screen, and if it's within timescale, prescribing to support the prescribing of antivirals. And obviously, again, it will just help decisions to be made around closure and opening of the home. As I say, up to 5 swabs obtained. And again, referring to your local pathways is really important to work out what's in place for swabbing in terms of transportation of swabs, who does them, and where the results are going to as well. So a little bit about antivirals and where they're indicated. It's obviously determining whether it is flu, and again, going back to those that definition, it can be quite tricky to diagnose. So it's really important that clinical assessment has taken place. Looking at whether there's been any hospital admissions, consideration if we're in flu season, or if we know that influenza-like illnesses are known to be circulating. And again, we can help support any decisions that are made by with any intelligence that we have here at UKHSA. Looking whether swabs have been taken and how long the results are expected to take. When was the onset of the last case, and how long it's been going on for. So an example of that is that I took a call the other day on our acute response desk, and when we actually got to the nitty-gritty of how long things had been going on for, we actually worked out that they'd been going on for approximately 10 days. So obviously we were too late in terms of prescribing of antivirals, but we did make attempts to try and get swabbing done to give us indication of what was happening and what was circulating, and whether it was a true flu diagnosis or it was another respiratory virus. And again, just really important for you to hold that information in terms of what your arrangements are locally. So NICE has provided guidance stating that antivirals may be used for the prophylaxis of those in risk groups following exposure to a person within the same household or residential setting, when we know that influenza-like illnesses are circulating in the community. I said there's generally two types of antivirals that are prescribed. I'm going to use the brand names because they're far easier to say. So we've got your Tamiflu, which is 75 milligrams twice a day for 5 days as your treatment dose, and your prophylaxis dose of 75 milligrams once a day, but for 10 days. Then we've got the Relenza, which is it's like an inhaler type treatment, and that needs to be given within 36 hours of determining that you've got flu cases within your setting. And again, the doses are written there as well. So your side effects really need to be considered. All of these medications do have side effects, and obviously we can stop these treatments if flu swabs do turn out to be negative. So just got another scenario. So this is a Tuesday morning. It's at the beginning of December. It's a small care home for individuals with learning disabilities. 5 out of the 13 residents are chesty, described as chesty. 2 have been prescribed antibiotics by the GP. All are fully vaccinated for flu and for COVID. And 2 out of 34 staff members are also off sick with flu. Recent COVID tests are negative and the CMO letter has been issued. Have we got any? What would we do next? Any takers? Thanks, Anne-Marie.
I was just going to say that you do the same risk assessment as you would have done previously, really, just to see, you know, how many affected, where was the index case, what was the relationship between the case, all of those sorts of things that you would do on a normal risk assessment.
Absolutely. And, you know, considering, you know, when that first onset of that case, are we still within that 48 hours of that initial onset? Can we get you know, antivirals prescribed, if they're deemed clinically appropriate. As I said, just making sure we don't miss out things, to say, providing that infection control advice, and, you know, recommending closure for those non-essential transfers as well, and closure for visitors. Yeah, so just a little bit about so we are able to access antivirals prescribing out of hours. As I say, each individual area will have their own specific arrangements, so something that's important to recognise in terms of, you know, what your local response is. But swabbing and results of swabs should not delay the prescribing of antivirals. You know, contact us ourselves at UKHSA. We are on call out of hours. There is always an on-call person and always an on-call consultant as well for advice and support with that. So this is just sort of a little bit of a side step, really. It's just, you know, considering again, life before COVID. Does anybody remember the swine flu outbreak back in 2009? Anybody remember that far back? Or has COVID stopped everybody's brain? Yeah, I'm assuming by the silence that you all remember it. So yeah, so the presentation of swine flu was, you know, presentation of that fever, cough, shortness of breath, and more frequently vomiting and diarrhea. The muscle aches, body aches, headaches, and fatigue. And some interesting statistics in terms of, you know, 28% of the hospitalised individuals with diagnosed swine flu, 28% of those were actually admitted to intensive care, and of those admitted, it's quite a broad figure, but between 12 and 59% developed an acute respiratory distress syndrome. Mortality was quite high. It was between 20 and 25%. And, you know, particularly severe outcomes were seen in pregnant women and patients with underlying respiratory and cardiac disease or diabetes. You know, and you know, it was from the swine flu outbreak that, you know, there was more recommendation for pregnant women to have the uptake of the flu vaccine. So the next slide's just a little bit more about flu vaccination. Just click onto the next slide for us, Kerry, that would be great. It's just some nice posters that there are available as resources. So, you know, flu is unpredictable, as you know, we've seen in past years prior to COVID. The vaccine provides the best protection against a virus that, you know, can cause quite severe illness. Flu can affect anyone, but if you've got a long-term health condition, the effects of flu can make it worse. And even if the condition is well managed, and even if it's normally well managed and you do feel well, so, you know, anybody with a condition that's, you know, you normally don't need additional treatment or support for, but, you know, because you manage it with medication or lifestyle, you know, you can still be affected quite severely by flu. Efficacy of the vaccine does vary from one season to the next, and overall efficacy is calculated between 50 and 60% for adults aged 18 to 65. There is, you know, lower efficacy is seen in the elderly, although immunisation is shown to reduce incidence of severe disease, including bronchopneumonia, hospital admissions and mortality. Provisional end of season adjusted vaccine effectiveness is estimated, you know, for the 2018-2019 showed an overall vaccine efficacy of 44.3% against laboratory confirmed infections, resulting that required a primary care consultation. So, and again, you know, there on the slides there is a little bit more information that is that's in the notes section about, you know, sort of particular studies around vaccine efficacy, you know, that people can access, and say it's in the reference section as well. So different types of vaccine. So none of the vaccines can cause clinical influenza in those that can be vaccinated. And I think that's quite an important take-home message, because we all have we always have that acquaintance that tells us that they got flu from the flu vaccine. The quadrivalent vaccine contains two subtypes of influenza A and birth B virus types, and the standard quadrivalent vaccine for those under 65 in risk groups, including healthcare workers and pregnant women. The adjuvanted quadrivalent injection is for those aged over 65. And the reason for the difference is in older people, we see a natural decline of their immune system with age, which makes them more vulnerable to becoming seriously ill. And it can also reduce the body's immune response to the flu vaccine, and therefore the adjuvant is added and it's designed to boost the immune response and to help compensate for that effect. So it helps compensate for that naturally reduced immunity of those who are aged over 65. And then we have a live vaccine, that is the nasal spray, which is offered to those aged 2 to 17. And again, there's additional information on the slides if anybody wants to access more information about the vaccine types. These are sort of this is sort of general literature that's available to those who are administering vaccines. You might see these on GP practices walls and things like that, and it just goes through again the different types of vaccines and who they should be prescribed to. So it's quite clear. And that is about it. Just got some useful links. As I say, there is some guidance, particularly around care homes. I have put a little star next to it on the next page. It was actually issued back in March 2020, but it is actually all due to be updated imminently. So, you know, again, just access that at your will, and, you know, bookmark the resources on your computer so that you can access them at all times. But happy to try and answer any questions or add any additional information if anybody's got anything they want to ask. I don't know if there's any questions in the chat box, is there? Yeah, Jasmine, I'm exactly the same. I struggle with yesterday, to be honest.
Have you got any more exercises you can share? It's always difficult to come up with them.
Haven't got any specific ones. I mean, generally, you know, that they all sort of generally run along the same theme. It's, you know, it's really getting that information about the setting, you know, trying to make that decision whether it is flu. But really, I think even, you know, without that information at hand, you know, in terms of a clinical assessment, you know, it's looking, have you got 2 or more residents with similar symptoms? And, you know, it's the bread and butter work that you need to do is to give that infection control advice, you know, which is going to be a key intervention that's going to stop the spread, really.
Yep.
So, I mean, as I say, I mean, was there any particular setting that you were thinking of?
I suppose because there've been some shared nationally, and they're all much of a muchness. You know, 5 or 6 cases. Sort of similar to yours as well. So I suppose it'd be nice to have somewhere. And they're all flu as well. So then it'd be nice to have somewhere it wasn't flu. You know,
I mean, an example of one that we had, I did, as I said, the other day on the ARC, and I'm forgetting to. It was basically we went through the whole process, provided all the advice, we arranged swabbing, we were out of time for antivirals. As I say, we recommended closure to the home, and it turned out to be an RSV virus. You know, as I say, but we still needed to go through that same process. And actually what we still want to do, even if it turns out not to be flu and it turns out to be another virus, or you know, turns out not to be, you know, anything that's
it's better safe than sorry, isn't it? And your general IPC advice is going to help, whatever it is.
Yeah, we want to, you know, you know, particularly in care homes, you know, the majority of these residents are extremely vulnerable in terms of, you know, not just their immunity, but the fact they're within close proximity of others. And, you know, we just want to do everything as possible to, you know, prevent that spread. I can see you said about the sharing the risk assessments. Absolutely, you know, we would routinely inform local authority. We're trying to sort of do a little step away from checklists, I think, because it can take away from the sort of analysis of what's actually going on. And, you know, anybody can do a tick box, but is it actually telling you what's going on in that home? You know, does it show that they are understanding the infection control advice? Because you know, particularly things around cohorting, and I can see Chris has put something about, is it Chris, about cohorted staff. I mean, absolutely, cohorted staff would be an ideal intervention. It's not always possible. You know, obviously with staffing levels of care homes, but that, you know, would be ideal, really. And yeah, processes apply to other settings. In principle, yeah, you know, the main intervention that you're going to do is provide that infection control advice. So, you know, thinking about nurseries and things like that. You know, it's, you know, recommending that children stay off out of the setting until they've recovered. You know, providing care advice. You know, making sure, you know, parents are seeking advice from clinicians if it's appropriate, if they are having you know, complications, and obviously, you know, again, just asking nurseries and schools to follow basic infection control advice, which, you know, is what we've been all doing all throughout the pandemic. And, you know, the advice is no difference. In fact, we're probably in a different situation because of the usage of PPE at the moment. I think it'd be interesting you know, maybe next year when maybe PPE usage isn't as high. Sorry, is there another hand up? I can't see.
It's Jasmine.
Hi, Jasmine.
Hi. You might have covered this already. Sorry, but There was a few of us were delayed
No
coming
problem.
on. And you might have covered the levels of infection currently. In care homes, the settings, sheltered housing, etc. South Staffs have quite a lot of such premises. What's the level of infection currently, or certainly since the beginning of the autumn period?
I haven't put a slide about it specifically. As I'm aware that the current data is that, you know, there is some evidence of flu circling, but we're nowhere near at the levels that we would normally expect at this time of year. So I think it's there, but not as prevalent as we've seen in other seasons prior to the pandemic. And I think there's probably lots of reasons for that, which, you know, which I'm sure you can all imagine the reasons for, in terms of, you know, we've got generally higher usage of PPE, and that there has generally been less mixing of people.
So, which is good news then, isn't it?
Yeah. As I
this
said, the last set of graphs I saw from last week from our FES team, you know, there was certainly some evidence, but nowhere near pre-pandemic levels.
Is it something that can be shared with local authorities generally? And I'm wondering whether it's something that can be added on as an extra slide in the IMTs that we have for COVID.
I can certainly take that back. Yeah, because there are certain documents that are produced by FES each week, and you know, see if that data can be shared.
Okay, thanks.
Is that another question, Michael?
It's just for Jasmine. It's Mike here at Staffs County Council. We have a weekly catch up with PHE on incidents and outbreaks, and we always get an update on flu. And as it's just been said, there's virtually been, certainly in Staffordshire, there's hardly been any cases, no real outbreaks. Yeah, a few single confirmed cases, but its circulation's pretty low at this point in time. But if there is a incidence, or the incidence does start to increase, we can just mention a Health Protection Board on a Wednesday.
Yeah, that sounds a good idea. Just to keep on top of it then.
You know, and I think the purpose of this training was that, although yes, we're not seeing it massively circulating at the moment, I think we've just got to be aware that it could come at any point. And obviously, because of particularly around the complication of that, you know, quite a similar presentation for COVID. So it's just, you know, getting people to consider other diagnoses other than COVID, particularly when you've got COVID negative results. And I think that's the scenario we're seeing, where we're doing, you know, lots more investigation, even if it doesn't turn out to be flu. Is, you know, well, all the care home was swabbed 3 days ago, and they're all negative. All the staff are LFT negative, but we've got 5, 6, 7 residents who are all sat there generally unwell, runny noses and a cough. Does that help?
Oh, that's brilliant. Thank you. Yeah.
Thank you. Is there any more questions? If not, I'm quite happy to leave it there, and obviously we can send out the slides to everybody. Believe Raj is going to sort out a certificate for those who want it. And obviously, you know, if you have got any questions, or, you know, any specific situations what you're unsure of, you know, back to the fact that, you know, we are available, you know, and we are available out of hours as well. Okie dokie. Thanks, everybody.
Thanks very much.
Thanks. Take care.
Thank you. Bye.
Thank you.
Thank
Bye.
you.
Thank you.
Thank
Thank you.
you.